I would like to draw your attention to the stage where we have our very special guest, Kelly Cronin, who is joined by Dr. David Kalber. As I mentioned earlier in the program, Kelly is the U.S. Health Reform Coordinator in the Office of National Coordinator for Health Information Technology. And in this role, she's involved in establishing and evolving the National Agenda for Health Information Technology in connection with the U.S. Department of Health and Human Services. She is joined by one of my favorite people, Dr. David Kalber. He is the Chief Medical Informatics Officer for Cleveland's Metro Health System, which is one of our public safety net hospitals and one of the largest, best-known ones in the country. Dr. Kalber, as many of you may know, is nationally recognized. In fact, in July, he was named one of the 30 leading CMIO experts by Health Data Management magazine. Under his guidance, Metro Health was selected as the 2015 HIMSS Enterprise Davies Award recipient. So, without further ado, Dr. Kalber and Kelly.
Great. Well, I think it's really a privilege and honor for me to be here. And really, I think the goal here is to try to have a facilitated discussion or conversation. I'll be doing some of that, here one-on-one. But also, as we were sort of doing with the first session, really encourage you to write on the cards on your table any questions you might have. And then probably around 11:30 or so, we'll collect those and hopefully be able to integrate your questions as well with the discussion. So I guess I would start off with, I think one of the things we were reflecting on when we first met this morning was that the Office of the National Coordinator was formed in 2004, and at least for me, that was just when I was starting to become involved and interested in informatics. And I was so excited that here's this whole brand of the federal government that's going to fix all of our health IT problems. I mean, that was sort of like, at least from my vantage point, that was really sort of the goal. And I think in part, it was really this idea of we need an organizing group to try to help us move forward. And so now we're pretty much in about 12 years on from that. And I think the vision that office, the ONC, started with, is different from where we are now in some good ways and maybe some not so good ways. Could you just sort of reflect on, as you see that journey over the last decade or so, what are some of the big wins that we've had, and then sort of what are some of the areas where we still have opportunities?
Yeah, great question. That sort of has been my life the last 12 years. I was the first person in the Office of the National Coordinator with David Brailer. So we got it started together, literally a startup in a large bureaucracy. I think a lot of what we started conceptually and strategically back in 2004 is still basically what we need to do. Sort of the overall plans were put in place. There weren't a lot of enabling laws, or there wasn't a lot of money. There wasn't like a policy framework that was operational, but the concept was there, and that strategic framework, I think, is still what we're operating off of at a high level. So just to recap on what that was really focusing on trying to have widespread adoption of electronic health records or point-of-care applications across the care continuum. And that's where we've had a big win that was touched on this morning, where most hospitals and physician offices are now using certified health IT. There are still gaps there, of course, with long-term post-acute care settings and behavioral health and several other sort of pockets of the care continuum that have not really been adopting ubiquitously, particularly with certified or interoperable technologies. Mm-hmm. Maybe some of the large chains that are well capitalized have adopted, but largely there's still gaps in the care continuum that we need to address. But it's basically been a big win in terms of having really most of the healthcare experiences digitized now. The other three components of that strategic framework that we started or put together in 2004 was also trying to connect the healthcare system, so really having sort of scalable ways of sharing data, both to push it where it needs to be pushed for care delivery, but also to be able to query when somebody shows up in the ER and is obtunded or might be seeking meds, and you just need to know more about them to be able to provide the care. So both push and pull. is, we've made some progress, but largely that, the levels of interoperability that we have in the system now are not what we need to have for full transformation. So there's an awful lot going on there that really in the last 2 years we've started to double down on more. We made progress with the Recovery Act, predominantly in these point-of-care applications being adopted in hospitals and doctors' offices. There was an element of that required interoperability and certification of the software that was being adopted. But just by nature of the way the Recovery Act was set up in high tech, it didn't really invest or have a lot of policies that were specifically around the middle layer of services. So how do we start to scale network services? How do we connect this healthcare system in a scalable way? How do you do identity management? What's the national approach for provider directories, or scalable, federated approach just to provider directories? There's a lot of patient identification, matching, linking. There's a lot of components to that middle layer, the network services, that were not fully addressed in high tech. And so we didn't necessarily have the authorities or the funding to sort of really go full throttle in that area. The focus really was mostly on the adoption of these applications in clinical care, and then we'll think about how to connect. So I think in retrospect, in that overall sort of second part of the strategic framework, we originally thought in 2004 that we need to heavily invest in standards and interoperability. And as we evolved through the decade, it wasn't always the top priority with new leaders that came in. Not that they didn't think it was important, it was just that the focus of what we had to get done wasn't always about the standards and making sure that they're harmonized and maturing and being specified enough and implemented enough in a consistent way that we'd realize the levels of interoperability, and that there was a definitive plan to really sort of execute on that had stakeholder buy-in, was really informed by the community, particularly of clinicians that need to be the end users of all the products. So we've learned, I think, that we probably did need to sort of rework in retrospect. I think this is my judgment anyway, not anything official, but we probably should have stuck with our original set of priorities where let's invest really heavily on the interoperability up front. Think about how scalable network services could work. What is the role of government in trying to foster that? And done that in a more deliberate way before we went full throttle into investing into point of care applications where there was a huge amount of federal subsidies that were really pushed really fast with a lot of expectations and reporting burden associated with that. And many would argue that while we've largely digitized the care experience, and a lot of that data resides within health systems or within these care settings, as was talked about this morning, it's not all available where it needs to be. There are just a lot of concerns that we didn't reach the full utility and in fact might have invested in legacy systems that didn't have the usability that we needed. They were largely, a lot of these tools were originally developed for encounter-based care and for sort of transactional-based things that would really serve reimbursement needs, but maybe not what ideally a clinician would want. And there's evolution in that, and the usability is improving, but it's been, widely sort of cited by clinicians as being a problem. So connectivity is something we're working really hard on, and have a lot underway to address that. But it's largely, I think, we haven't progressed as much as we need to now, particularly given the focus on how important payment reform is in healthcare and how we really want to see these new models of care that are person-centered and fundamentally based on better care coordination. If those models of care with the right payment schemes are going to be broadly adopted and we're going to reach the Secretaries of HHS's goals and the private sector's goals of sort of matching that, with commercial payers moving in that direction, we really need to be thinking more deliberately about how we're going to make more progress with interoperability. We had an interoperability roadmap that we released over a year and a half ago at this point, which laid out a lot of steps that we're taking, and had a lot of industry input, stakeholder input, and it's really a collaborative process. It's not a federal plan. It's really, we're all in on this and really trying to think as a larger community, what are the set of things we need to get done, and we've made good progress. so far, but the original or the short-term focus of that is just send, find, and receive a common clinical data set across the care continuum, which is really important for what we need to do, but it's not all that we need to do. There's so many other things around quality improvement and public health and really all the steps that we need to take to get to the patient being fully empowered, and also sort of create a learning health system. So it was a really important set of actions in the next 3 years that need to all sort of continue to happen. But we also need to know the 3 to 6 year period is equally important that we're really starting to think a lot about. So going back to the original framework we set up in 2004, we've great progress with adoption of EHRs, a little less so with connectivity, but we're really doubling down. The consumer empowerment piece was also the original part of our plan. And I think, now, as was talked about this morning, there's a huge explosion of opportunity and great innovation happening with all companies of all sizes. But there are a lot of challenges, not just security that was talked about this morning, but how to really fully integrate into the care experience. So it's great that everybody with their iPhones or smartphones can have cool apps, and maybe they're empowered to do more wellness and more, monitoring, and maybe encouraged from a behavioral perspective to do the right thing. But are they really tethered enough to the care experience and able to be connected on a bidirectional basis with the clinicians that are caring for them? Particularly if they're chronically ill, they're going to be, probably seeing multiple people and really need that virtual care team to be interacting with their app. So I think that while we've seen a lot of innovation in industry, really stepping up with great ideas, and that'll continue. But I think we have a lot to think about when we, get to sort of the next set of federal policies and standards to think about what is it that we need to do to make sure that that bidirectional exchange between the patient and the healthcare system, or the patient and the social services, whatever they might need to really fully manage and be supported where they need to be. So good progress there, and we've had some role in that, but I think a lot of that's been industry stepping up. Meaningful Use had some provisions that really helped with portability of data. A majority of hospitals now are able to not only download a summary record, but also share it electronically with the patient. So that's been a huge improvement. Even in the last 2 years, there's been a marked improvement among health systems alone. And then getting into the fourth category, it's sort of all, from the original strategic framework, it's all around secondary uses. So for quality improvement, for population health, for public health surveillance, a lot of public health functions, whether it's responding to the Zika crisis or many other Ebola, many other emergent needs. And then research. I mean, really to get to a learning health system where we have data that's really easily and appropriately shared for research purposes, so that you have these aggregated data sets that can be used for advancing precision medicine, advancing what we know to be cost effective. There's just a million different research applications that could be better served if we had a more robust infrastructure around how to capture that data for research, get consent for that process, and be able to really use that sort of mapped and normalized data at a large scale to be able to really learn what's working, and really be able to apply those learnings back into the healthcare system, have executable clinical decision support that a lot of EHRs could accept as appropriate. And then I think the quality improvement piece in particular, we've had a lot of improvement on how we can specify electronic clinical quality measures. We've gotten better at that over the years. We started off maybe not so good, Meaningful Use stage 1, but made a lot of improvements. We have a better standard now for that, a QRDA, for those of you who follow this. And we have also are starting to spend a lot more time thinking about, again, what's the middle layer look like, not just what does the EHR spit out in terms of a more structured set of data elements that's in an envelope that can be processed and calculated into a measure. But how do you make sure that if you're actually trying to hold a team accountable for diabetes control, that you're not calculating the wrong A1C over time, the wrong mean. Because if you don't capture the endocrinologist and the PCP data in calculating that measure, you're going to have missing data elements, and you could actually have a really flawed measure result that's being tied to your payment. So without the ability to sort of aggregate and think about a care team that should be attributed and held accountable as a team, not just individual clinicians, but increasingly as team-based care becomes the way of the future, it's really understanding across settings, in many cases, they're not all co-located, but across settings, how is that team working together? And then how are you calculating that data from these various different systems that are exporting it? How do we calculate those reliable measures and make sure that everyone's encouraged to work together as a team, they're working for the patient, and it's patient-centered care, and then as they get measured and they see that data, that it's valid, it's reliable, it's good enough for them to inform their own performance and their own actions, data-driven improvement, but it's also good enough to base a lot of payment on. So I think beyond what we've been able to figure out with how to make measures more, codifiable or computable, how do we make sure that we're going to be able to scale a bunch of aggregators that can look at data longitudinally and provide that feedback. And it's not just the Aetna view on performance or the United view on performance or the Medicare view, but doctors we hear repeatedly for the last many years, they want to know the entire panel population. They want a payer-specific view of their data. So having sort of proprietary solutions for this performance feedback isn't necessarily meeting their needs. And particularly as we think about scaling these alternative payment models, the goal is not just for Medicare to go in this direction, but for all payers to move towards value-based payments so everybody can make this big push to these new models together, and you're not managing 20 different business portfolios with 20 different benchmarking methodologies that drive any CFO crazy, right? Even though that is the reality in much of the market today. But to try to get more alignment on how we act together across public and private sector payers, to sort of move in this direction. Part of that is trying to figure out how we can think on a shared service basis, how do we get more of a comprehensive view on performance so that they can be trying to make these improvements within systems based on the common view. And also not having them report 10 different times to 10 different payers or end users of that information. It's too burdensome. Mm-hmm. So the concept of report once that CMS has really embraced is important, but then we need the infrastructure to support that report once. If it's calculated once and you have the right denominator, send it to everybody.
Yep.
So for the quality improvement and the quality reporting and feedback and that part of the secondary uses, I think we've made some advances, but still have some really important improvements to make in the near term, particularly as macro is implemented, and there's a lot riding on it. And then there's a lot of improvements we've made in public health on an iterative basis. There's been some really neat partnerships even recently with, because of so much of the concern around Ebola and Zika, that a lot of health IT companies have stepped up to try to do very quick, actionable things that are going to help providers. I mean, you've probably lived more through this than I just know about it. You've lived through it. Anyway, so I think there's been some really neat improvements, immunization registries and sharing with that, a lot of upgrades on what's happening at a state level in that area. So we've made some improvements, but there's an awful lot more that needs to happen there too, and a lot of coordination across different jurisdictions, which is always the case in public health, right? It's CDC plus the state and the county, and that's all very complicated. And but I think there have been pockets of the country where that's really worked well. So I guess a quick synopsis is we've made improvements across the 4 areas in the strategic framework, some a lot more than others. And the biggest win is EHR adoption, and really an awful lot more work that needs to happen across the other 3.
Good. With that backdrop, can you talk about a couple of the priorities in the next couple years that your office in particular is working on?
Yeah, so my team right now is really focused on trying to figure out what we need to do to evolve sort of the health IT broadly to support this transition to payment reform and new care models. And we have been talking a lot to CMIOs across the country and done some research, and also just convened a lot of public meetings and whatnot. Have a lot of different inputs to figure out what are these sort of priority needs that the market hasn't yet met in a systematic way. Maybe there's a couple really cool innovators, but yet hasn't been scaled. And maybe there's not a good standards-based approach for some things that need standards. So for example, 2 areas that have been brought up as important needs, really for any ACO or any patient-centered medical home, advanced primary care model. You need to be able to do referral management. Mm-hmm. And you need to be able to do a shared care plan. You need to be able to work between a PCP and a specialist, and ideally the patient, to be able to say, this is our plan. This is what we're going to do. Here's your problem. Here's your, as you stated, here are your preferences, or here's what you want to accomplish as a patient. And here's what we're going to do as a team to meet that. Well, that should be something that everyone manages to and is available and is updated as appropriate. But we don't actually have standard. We have emerging standards to support that. Just as in referral management, there's a couple places in the country where this happens well, but there's actually not a mature set of standards that enables it. And there should be sort of a dial tone for that, you know, to be able to, it's more than just exporting a summary record from a primary care doc to a specialist that isn't always consumed well or actionable. It's actually having a referral note that's standardized that can be sent, and that the referral loop can be closed, and at any point in time, you know the status of, let's say, the 500 referrals you have out in a large practice, and you know which ones that are urgent, where somebody has end-stage CHF and they really needed to be seen, were they seen or not, and what was the outcome. So I think knowing how to sort of track all that and having the standards-based approach to scaling that across EHRs or across combination of EHRs and population health platforms is something we're working on, and that it's not a government-driven solution. That's an example of something that the standards community really needs to partner with the clinical community and say, this is the best approach. This is actually something AMA really cares a lot about. They want to figure out a scalable approach to close the referral loop because they realize this is important for MACRA. It's important for a lot of people what they want to do. And they've actually been great partners in trying to identify the sites that the solutions can be tested, and then standards development organizations play an important role in doing the convening and the development of the standards for draft standard for trial use. I mean, there's a lot of players, and we play a coordination role, and then eventually when something is ready for more formal adoption and scaling, we can incorporate it into our rulemaking. So, with care plans, we're a little bit further along in that we have a structured template that's part of a summary record. So we can say, okay, we're not yet at a dynamic care plan. We know exactly how we're going to scale that and a standards for it. There's maybe a FHIR-based approach to that. But at least we can say, you need a problem list. You need to know the patient goals. Like, there's some fundamentals that should be structured and shared. And that is something that you don't really need to argue on. We had a lot of geriatricians and good, very good, smart clinicians telling us what those are, and a collaborative process and an SDO that blessed that and it's been implemented. So that is on our regulation right now, that care plan standard, so that there could be a broad adoption of that. Now, there also needs to be innovation on that, so you can get to this dynamic shared care plan where a virtual care team can make updates and be able to share that. And there's a lot of really great experimentation going on in New York City around that right now. And the VA is also quite interested. So there's both the need for us to be thinking about what are these new priority areas, like care planning, like referral management, like patient-reported outcomes. We don't have a scalable approach to make those computable. And that data should be able to be captured by certified technology, supported by it. And so there's the whole host of those priority areas we've been identifying, and then thinking, okay, what is the logical standard strategy based on what everybody's telling us across all these different communities, and then how does it get done? What is the logical path to really accelerate this? Because there's a lot riding on these things. You can't just sort of sit back and think they're going to naturally evolve. There needs to be some orchestration to really accelerate the maturation of these standards and the innovation around them too in the field. And then there's the path of what we've also been thinking through is once we have this set of, say, 10 or so priorities that we're working on, it's the next generation past meaningful use, right? Beyond where we currently are with the certification program and what was meaningful use. Then we need to think, okay, what's the relationship then to MIPS and MACRA? And if you don't know this is the Medicare chip and reauthorization. Or yeah, you all know that. So the MIPS is the merit-based incentive payment system where a majority of clinicians will start off in the next year. And the final rule is pending, so I can't talk a lot about it, but basically by statute, there's two different paths with MACRA. You start off in MIPS or you start off in advanced alternative payment models. And once we have sort of these new priority functions and standards to support them, we can then introduce them through the MIPS. So it could be through the clinical practice improvement activities where you have an incentive perhaps to do shared care planning and the use of the standards to support that. Or you have use to do, or encouragement to do remote monitoring that uses a standards-based approach to share device data. Or you have, other types of, like there's an ECQM for closing the referral loop in the quality domain. So we think across the MIPS domains, you start to embed these incentives. And then over time, it becomes sort of the common expectation for advanced APM. So we need to sort of drive the iterative adoption of these things through our payment policy. So that's really what we're spending a lot of time on internally, but really informed a lot by what people are telling us in the field of what they need. It's not a bunch of feds sort of sitting in a room. Even we have a lot of doctors and nurses and pharmacists in ONC now, which is terrific, more than we ever had before. Super smart people, dedicated, but we need to listen to everybody in the healthcare system, which is really who we're serving, along with patients. So that's a big piece of what we're doing. We're also trying to figure out what does this middle layer of aggregation look like, because we're really keenly aware that you can't expect 100 commercial payers to have 1,000 different connections to every single analytics company or clinical data registry or an all-payer claims database or an individual ACO. It's just not scalable. So we need to be thinking about what does that middle layer, a more rational middle layer look like if we think that a majority of providers in the next 5 years are going to be under alternative payment models, both commercial and Medicare and Medicaid. That means that they're going to need cost data across those payers. And a small doctor's office can't do that integration. It's not realistic. And it's not even realistic for a lot of health systems that don't have the capital to put into the best vendor that does that. So we are trying to think through what is a more rational approach for that, and how does clinical data get linked and integrated? Can there be some economies of scale there that can make it easier and actually reduce the barriers to entry for new companies that want to get into this space? They can focus more on how the innovative uses of that data and the analytics around that, but not necessarily worry about the complexity of the linking and the mapping.
I mean, it seems like from these comments and even some of your comments before, you really consider interoperability as sort of one of the keys to moving forward. And I guess I don't know if you can dig into that anymore. I think our experience at Metro, we're sort of a very early adopter of health information exchanges. So we've actually published on how it's decreased admissions and decreased utilization, which is great, although it actually hurts us financially, in the current model when we're doing that. We found good success with our vendor-based health information exchange, where I was just at a meeting last week, and within our vendor-based health information exchange, there's 1 million patient records transmitted per day, across the country. So we see some real highlights. Although on the other hand, we were one of the first people to try to exchange with the VA, but we're sort of stuck with that hasn't worked well at all because the veteran has to have permission on file at the VA, before any information can, transmit over. And we do exchange with Social Security Administration. We also do exchange with our state-based health information exchange. But I think although there's some successes, it just seems really hard. It's really hard technically. The data that we get through these exchanges is better than nothing, but it's still for a lot of times not sort of machine interpretable. And then on those few cases where it is machine interpretable, so we get meds, allergies, problems, immunizations, but they all have to be reconciled. And I was just looking at a report this morning, in the last month, we've had over 100,000 meds, problems, allergies, and immunizations coming into our system, but nobody's doing anything with them, because that's a whole, it's work we should have been doing, but the reality is in our current healthcare environment, nobody has time to be sort of looking at all this. So even though in some cases we're starting to get information, we're still not really using it because we haven't figured out the workflows for that. So again, I don't know if you could sort of talk in a little bit more detail about sort of what are some of the real opportunities with health information exchange.
Yeah, there's enormous opportunities. I think maybe start with some of the challenges, because I've lived through a lot of that in the last 10 years. Just in terms of trying to stand up the federal programs that we hoped were going to be wildly successful and weren't always. It's really hard to orchestrate local politics. You can't, right? I mean, from afar, right? You can't sort of say, okay, all your large health systems work together to make something happen. It's going to be in their financial interests, or their culture is going to drive it, or the leadership commitment's going to drive it. Or sometimes in case it's just one really very talented person that can pull it all together, like in Tulsa, Oklahoma, or in Maine, or there's a handful of places in the country, or Michigan's another good example, where there's been really exceptional people that have created HIEs, and they've made a lot of progress. I mean, they had a supportive community and supported Medicaid policies and the rest, but a lot of it came down to the individual and the team around them. So not being able to sort of orchestrate what happens in Philadelphia or Chicago or LA or some of these really tough markets where there's academic medical centers that are just really very competitive. And without sort of the financial imperative or the business imperative to share the data across their markets. You can try. I mean, what are basically the biggest overriding policy there that's going to start to change things is all these new payment models, right? I mean, if you're accountable for a total cost of care, whether it's at an episode or population level, you're going to care about what happens after they leave the hospital. And you're going to want to work with all your community partners. I mean, the readmission penalties under Medicare are starting to move the needle a little bit, but I think a more holistic set of payment policies are really going to start to drive that. So I think that's going to maybe wake up different levels of leadership within health systems if they haven't already decided to do something. But in some ways, Cleveland's a really good example where, I mean, you know this better than I do, but when I've looked at it from afar, Cleveland Clinic and Metro Health and the other large health systems, some are in Epic, others are not. But there isn't necessarily a community-wide solution to be able to share on a regular basis, and without investing in a way to do that, you're not necessarily going to build up the capacity to get to the machine-readable data. It won't be shared and consumable in an actionable way. I'm not saying it all has to be community-based, because there's just going to be parts of the country where that will never work. But in Cincinnati, it's actually working very well, and they are very well served by HealthBridge. I think that because there's all these challenges, some have been technical, some have been political, some have been cultural, we have tried to address this the best we can from a federal policy perspective, advancing standards the best we can. There's still more that needs to be done there. The other piece of this, beyond the financial incentives, which are evolving and will continue to evolve, and improvement of the standards, is making sure that there's governance that's understood. So there's a better approach to scaling consent policies, computable consent. There's ways of doing trust agreements, or figuring out how you're going to do reciprocal data sharing from one network to another, and what's the dispute resolution process. There's all these technical things that need to be worked out, but you need that governance layer to sort of allow for that kind of sharing to work more seamlessly. And we've made progress in that area, but as an office, as an organization within HHS, we actually don't have a lot of authority to address that definitively. We have like one little provision in high tech that our general counsel is telling us won't take us very far. So I think there's going to be, in the next several years, a recognition that that's going to have to be addressed. It's not that it's all a regulated solution, but there has to be something that's more scalable than what's currently going on in order to truly have like an operational network of networks. If you look at Michigan and New York, they've created a network of networks through their own policy approach, and it's working. So I think there's really good like lessons that we can incorporate as we start to think about what's the scalable approach.
Okay. I guess I would encourage people in the audience, if you have questions you want to write down, I think someone will be coming around to pick them up. I don't know if you can provide insights on sort of the evolution of policy to individual practice. And so I think one of the things that I would reflect upon as a CMIO at Metro is, as things like meaningful use or, MIPS and MACRA and the alternative payment models, it seems to take so long to come up with the final rules. So, again, you use the example of, my understanding is, Metro is supposed to be in one of these things by January 1, but yet the government is still finalizing the rule. Or the meaningful use example is, we're in the 2016 reporting period, but yet there's still the expectation that the rules will be revised probably by the end of the year, but no one can commit to that. So I guess I've seen in this spirit of trying to innovate rapidly at the policy level, which I think is good. For a healthcare system, usually we're dependent on our vendor in a lot of ways. So we got to get the policy finalized. Then we got to get the vendor to a lot of times make changes, electronic health record vendor, and then we have to implement those changes. And sometimes it just seems like, it'll take a long, long time for the policy to really be finalized, which we can't control. Then we can't control our vendors to the most extent, but yet there's sort of hard deadlines. And so either healthcare systems don't succeed with that, or again, I'd say at least with meaningful use, then there's basically this big push to roll back the timelines. So I don't know if you can speak to your perspective on any of that.
Yeah, it's tough because you're at the mercy of a lot of different pressures, right? So I think people are very sympathetic to the true burden right now in the healthcare system, and much more in touch, I would say, now than many years back, and on a federal level. But that said, you've got statutory deadlines. By law, we have to implement something by a certain date. And then you also have just this Administrative Procedures Act that oversees how you do rulemaking, right? So there's all this fine print and all this process you have to do. It's the law to do a good rule, a final rule. And the public comment process, you get boatloads, like thousands and thousands and thousands of comments. You have to respond to every one of them, And it's good. It's good due process, but it's hard. And then there's a lot of negotiation that goes on to try to do the tuning of the policy that's workable, that you think is workable, and the right thing to do. And there's a lot of balances and trade-offs in trying to make that call. And I think Andy Slavitt, the current administrator of CMS, has been very vocal about, we may not get all this right completely when we are launching MACRA. And we're going to be starting as sort of this, baseline year that will be almost like a trial period, that we're going to have to learn our way into this, and there will be improvements over time. So I think there's a different notion of this is going to be law of land, never will it change. It's an iterative process, and we're all going to have to sort of make this work. I think we've learned that through meaningful use too, because as it was originally conceptualized, 6 years ago or so, the 3 stages didn't all play out the way that they did. It was actually a very nice logic model that Paul Tang and others came up with. But then in practice, it was incredibly burdensome and very difficult for people to actually do the measures, right? And so we learned that we needed to change that. And you saw that in part through the proposed rule with MACRA, where meaningful use is now one of 4 components in MIPS. And it's really streamlined more the original set of measures that were projected to be part of stage 2 or stage 3. So I think we've learned to be responsive. That the trick and the challenge is, how do you do that fast, and how do you do that to allow enough lead time for vendors to make the changes. So I think one thing ONC is really consistently doing now is we are sort of the, we're sort of the health IT geeks that tell everybody what you can do and what you can't do, and what's in our regulation that should link and not link to the different aspects of the CMS laws or CMS rules. But we have to also be the ones that are balancing the timelines and they say, no, actually you need a 2-year timeline for this because they're not going to get it in on time and then it'll be a failure and no one will be happy, right? So we are very mindful of the lead times and are always incorporating that into our internal discussions. So I think, everyone's learning through this process, no matter where you sit, whether you're in government, in ONC, in CMS, and frontline provider, CMIO. I think we're all trying to sort of do the best we can, but there have been some very high expectations and times we know that there hasn't been enough lead time and that's caused a lot of pain.
Mm-hmm. Were there some questions from the audience? Okay, great. So here's a question. Is interoperability really possible without a nationwide central repository? This is a step we seem unwilling to take for some very good reasons, but it seems to be a roadblock.
Great question. I think a lot of privacy advocates would have an enormous amount of concern with a centralized repository. I mean, that's goes back to having sort of a national patient ID, which legally we're not allowed to pursue on the federal level, or spend money on anyway. It could yield a lot of utility, but the other piece of that is that when there has been a national approach to aggregation tried, I think Blue Cross Blue Shield tried this years ago through RX Intelligence. There's now national Medicare qualified entities. They're trying to do this with administrative data, all payer data. It's very difficult to do it on a national level to make it executable and relevant on a local level because there's so much complexity and the volume of data. But on a regional level, it's proven to actually work pretty well. I mean, there's many different working examples of HIEs that do have either federated or centralized repositories that are yielding huge utility, particularly around reporting and analytics and preparing those communities that they serve for payment reform. But to take it to a national level, I don't know that from a privacy perspective would ever be accepted. And I think technically it's a little bit challenging. It's not necessarily easy to make that, to map and normalize data at a national level would be enormously complex. Particularly sort of where we are right now with semantic interoperability. There's so much variation with underlying, medical terminologies and codes that are used within different systems. So I think but what I mentioned before, part of what we are trying to really think through right now is what does that middle layer of aggregation look like and how do we create more efficiencies? Because while it may not be a national approach, it does need to be something different from where we are today. You can't expect every single ACO to be able to replicate, multi-payer claims and clinical data assets and expect, critical access hospitals to step up and do that or patient-centered medical homes to do that, So there does need to be a more efficient approach, and we are trying to figure out what's the combination of what needs to happen in industry and what's federal government role for making that happen.
Can you speak at all? I think this was alluded to in the first panel, and we've seen this at Metro too, this whole idea of healthcare systems right now still have one foot in the pay for volume, but also are being asked to have one foot in the pay for value. But I think the challenge is a lot of times the technology investment and even the operational investment in pay for value, it scales well, but you have to make a huge upfront investment. And even for a place like Metro Health, we say we're 50% in risk contracting now, which we are, but it's through like the Medicare Shared Savings ACO and some commercial ACOs. We're still within those risk contracts, 95, 98% of our actual revenue, is still tied to a, pay for volume type of, arrangement. So I guess it's, again, I think probably from your perspective, it's a question, on some level, I was using the analogy this morning, I think you want to rip off the Band-Aid as fast as possible to get people to that pay for value. But still, you could rip it off too fast, and then people can't get there. The wound hasn't healed enough, and you're still gushing blood out. So I don't know if you can speak at all to sort of how you're thinking about that at ONC.
Yeah, it's a HHS concern that the secretary has been very forthcoming with setting goals for Medicare, where, by 2018 they want 50% of Medicare payments in alternative payment models. Some of that is on a fee-for-service chassis, like Medicare Shared Savings Program. But yeah, I think part of the idea is to be very definitive about setting a goal that's measurable, and then have partnerships with the private sector to make sure that we are working together as a nation to really shift as fast as feasible to population-based payments. So in the last year, CMS has created or helped foster the Healthcare Payment Learning and Action Network, which has leaders from private payers, health systems, consumer advocates, a variety of purchasers, state leaders. It's really a multi-stakeholder group that's intended to really think about how we scale payment reform and how fast can we go, and how do we learn from our various positions, how do we learn how to work together to make this happen and make it succeed. And so part of what they're doing is benchmarking progress and trying to figure out how do we replicate and scale as quickly as possible. So that they've actually had a process where they've taken the HHS goals for payment reform, and then they've asked all the commercial payers to step up and also publicly state how fast they're going to move and how much of their proportion of their payments they're going to move. So there's been a lot of progress, and there'll be national, there'll be visibility on where we are as a nation with making that progress. So there is a deliberate process and sort of multi-stakeholder commitment to making this shift. I would say most people involved in both on the federal side and at least through this network, and a lot of the commercial plans, I think, do want to make this shift as reasonably as fast as possible. Purchasers clearly want it, large employers in particular. But I think, at the same time, there's a huge amount of fatigue in the system, and part of the learn our way into it is to figure out how we do this so that we're supporting changes in clinical workflow, and we're teaching people how best to make not only the technology implementations as smooth as possible, the care process redesign replicable, but that we also have a way of getting some alignment around, whether it's the set of measures that are going to be routinely implemented across payers, but also benchmarking methodologies or other aspects of sort of the payment operations that shouldn't be overly cumbersome. There should be some degree of congruence and alignment to the extent that it's feasible. So that will play into how fast we move, right? We can't have too much complexity in all this. It'll break the system. So there's a lot of thought and a lot of smart people spending time on how fast can we move and how fast can we commit to that.
Okay. Here's another question from the audience. It says, your latest publication entitled EHR Contracts Untangled. I don't know if that was yours in particular or ONC. Yeah. Are you able to discuss that at all?
Sure, yeah. This is something that we've wanted to do for a while, and it addresses a lot of needs in the market, at least we intended to address a lot of needs, where a lot of providers we've heard over the years don't always understand the fine print in their EHR contracts, particularly those organizations that don't have a sophisticated CMIO like you, who really know what you want, and you have very refined business requirements, and you probably have other contracting team to do a lot of the procurement with legal support. Not everybody has that. So there is also just a huge amount of concern that data is not being shared when and where possible, or when it's really needed, and there are some contractual barriers when it comes to, or information blocking is one term that's been used a lot. So we're trying to get visibility and transparency around how do you negotiate to make sure that you're not going to end up with contracts that are going to limit the utility of the data in the systems that you're contracting for. Be very explicit up front about what you want. If there's a set of promises on functionality and requirements that have been part of your negotiation, make sure it's in that contract, and that there's an obligation to be held to. So there's a lot of practical insights, even dealing with third parties. You know, there's we get a lot of anecdotal input from analytics vendors that they can't get data out of the EHR, and the vendor's not being cooperative. Now, you know, we ultimately, you always need fact-based. You need to do fact-based determinations. It's how FTC operates. It's how most government operates. You need to really be able to fully explore something with the details. But we've gotten a lot of reports in from people, and FTC and others have really started to look at this, and there does seem to be some there with the problem. So this contract guide is really intended to really help inform providers about what they need to do to make sure that they have an informed and transparent process in contracting for products and services, and that they really do look at the fine print and they pay attention to the fine print.
Great. Well, I think last question, assuming your office, ONC, is amazingly successful over the next decade, can you give us some sort of vision of where you would expect or hope that we would be in that sort of framework?
Yeah, I guess I'll just modify a little bit of what you said. I don't think it would be ONC specific, but as a community, if we were really successful, you know, if the federal government got all the policy stuff right and implemented the programs right, and if industry evolved and stepped up and responded in the right way, and providers were able to deal with all the change, assuming all that happens, I think that we would be an incredibly different healthcare system where it would be truly person-centered, and a person would be able to receive care when and where they need it without going to a doctor's office or without necessarily being in the hospital or in a skilled nursing facility. We have a huge aging population that we're all acutely aware of that's growing, and they want to be at home. Mm-hmm. They want to be independent and at home, and there's no reason with technology and a virtual care team and the right supports, the right social interdisciplinary team and services, that they should be able to be maintained and healthy at home and have their caregiver and their family around them to help them. So I think that, you know, if we get the device interoperability down, we get the connectivity across the care continuum down, we start to see more adoption in long-term services and supports of technologies that can connect them. So community-based services, social services, if they can become part of sort of the interdisciplinary virtual care team and be able to get the right kinds of access to information to be able to get meals delivered on time, housing support, whatever is needed, because we all know social determinants play such a huge role in maintaining the vulnerable populations. You know, that all could be really transformational. And I think we'll have much more visibility on the true performance of the system and individual providers, really at all different levels. You'll know individual clinicians' performances, you'll know at a group or a care team level what's happening, you know, at a population or community level what's happening, and then we'll be able to, from a policy perspective, be able to benchmark nationally where we are. So if we really do get everything much more computable and have that, you know, better integration and mapping and analytics of the data, we'll be able to do an awful lot to understand performance, but really drive improvements. And related to that, you know, is really having all that data to be able to truly make good value-based determinations. So to be able to scale and sustain payment reform, it really is very dependent on that data, reliable data for value, for both the total cost of care, the various cost metrics, but also you know, various ways of looking at quality, including longitudinal outcomes. And patient-reported outcomes. We'll be able to really understand from a patient's perspective, this was important to me, and this is what my care team did for me. And they either met what I wanted or they didn't. And so I think the accountability will come back, will be more at that level. It'll certainly be at a total cost of care level, and at measures that matter, you know, around really improving care. But it'll also be like, what's really important to the patient? Sometimes it's walking their dog, you know, especially when they're at home and alone, and, you know, it may not be something about managing their diabetes. So I think to truly be person-centered, you know, all this needs to evolve. applications need to be better across the care continuum and connected. We need better APIs. We need to be able to not only get data out of the EHRs, but be able to consume clinical decision support that's more computable and meaningful without alert fatigue. And,
Right.
Obviously address the security risks, so we're not going to have major breaches that are going to paralyze people. That's a huge concern, as was talked about earlier. So we'll have better policies, operational policies in place for that, I think, in a perfect world. What else? Yeah, and I guess even if you're a well person, you've got a lot going for you. If you have not only technology supporting your behavior, but for those that are sick, you have technology helping you do your own self-management. So yeah, there's a lot of room for improvement, but I think some of the bigger shifts we'll see is really shift away from institutional care, particularly in long-term care, and hopefully really supporting people at home.
Great, that's a powerful vision. Very much appreciate you taking the time to speak with us and have a conversation this morning.
Okay.
Thank you very much.
Thank you.